Hello everyone, and good afternoon if you're joining in from a country where this is afternoon. Welcome to the Samueli Initiative Seminar on Responsible AI in Medicine. My name is Oren Asman, and it is my honor to moderate today's event. You may notice my colleague here, Amir, we share the same background. I mean, the technical background. And he's an important part of actually having all this event coming together and the seminar and our activities. And it's really wonderful to have colleagues here. Many are from Israel, but also from other countries. And that is one of the main reasons we do these meetings in English, so that we can have international participation and input, and as a part of how we understand the growing community and discussion on AI, which is really not local in essence. And so we already thank our speaker, which we present soon. Let me first kind of apologize that we postponed this meeting, which was originally set for last week, and we're really happy that you rejoined us today. I just want to say that I'm going to share very shortly what we're doing at the Samueli Initiative. For those of you who have not heard or would like to get a sense of what we do and potentially join in on more activities and events, our email is here, and you could contact us through that or different social media outlets like Facebook, Instagram, and our website. We'll present today's speaker in a minute. So what we believe is that when we talk about responsible use, development, planning, and integration of artificial intelligence in the field of medicine, we see this as something that should be considered by a wide array of professionals, not just healthcare professionals, but also not just AI or technical experts, but rather a venue of expertise that could include philosophers and people dealing with legal aspects, social aspects, psychological aspects, and so on, because the scalability and the possibilities that are quite unique, but also the potential risks that may ensue. And so we have gathered over the time that we started to initiate this initiative, people from different countries, different expertise, to kind of work together in a multidisciplinary, international, and very diverse approach. We started these seminars last year. So we've had 5 seminars in English, and then summer came, summer break, and then a horrific attack on Israel changed a lot of things and kind of postponed the semesters and some of the activities. And when we were back to some extent to kind of recuperate and start working on this again, our first event was in Hebrew, focused on responsible use of AI in medicine during wartime, because of many of the unique experiences and needs that we had, some related to identifying those who have been murdered, some related to other things. There was a vast amount, and there is still a vast amount of new initiatives and technological ventures that relate to medicine in various ways, that kind of accelerated during this time to offer very much needed solutions. But that also created questions about, do we still apply the same ethical and responsibility related rules if we know what they are? Or is it when we are in a rush to find solutions because this is war, then maybe things could be kind of be rushed into so that we can get solutions quicker? Which is something we discussed in this seminar that received a lot of attention and interest. And as I said last week, so within a few days, we're going to announced the winners of our first round of grants for researchers, interdisciplinary groups of researchers, to students, and also to those who have suggested to set up discussion groups or research groups. So that will probably allow many of you who are interested to either join some of these groups, or if you're interested in setting up a different kind of group and you have something in mind, we're open to suggestions, and we're happy to hear what you have in mind. Just to get a sense of what we mean by that, and I'm sorry for maybe repeating some of that if some of you heard that last time, but as things happen, this is from today. It was published a few minutes ago, so I'm happy to show you that. I just got it. So the first group that we have started to operate within our initiative relates to mental health. And so this could be as an example to different stuff that people could do when working in an interdisciplinary group. So in our group, we have psychologists, and we have other kind of therapists and philosophers and jurists and psychiatrists and others. And we started discussing the theoretical perspectives of relating to generative language model as an other, as potentially as a caregiver. And so we published several papers. Our theme issue on responsible generative AI in mental health received quite a lot of submissions. Many of them are very interesting, and it should be published within a few months. Some of the papers have already been published as preprints or as before print kind of publications. So there's a lot going on, and some of the papers needed much more focus on what's the responsible angle. So again, I think today Giovanni might, Professor Rubeis will discuss what it means, the way he sees it, discussing what's responsible use of these technologies. A lot of people focus on the technologies, as we saw in the submissions. It's a bit harder to focus on how do you do that responsibly, and not just get excited by what the technology can do, which is exciting, to be honest. I think it's quite exciting. So there are a lot of activities. Some of them are in Hebrew. The one on this Thursday, so the 7th of March, it's going to be in the evening. It's with the Artificial Third group. This group that works with our group has been existing for about a year, and there are like 4,000 people participating in it, which is quite amazing, and almost 700 registering for Tuesday's meeting. So there's a lot of people very interested, a lot of caregivers interested in what AI could mean for their work. And I'm kind of sharing that with you, Giovanni, because I'm thinking that it would be of a lot of interest to hear how you think about those things. And let me just say that so in this group, we have several amazing people. You see some of them here. So Yuval Haver, he set this group up with Tal Angel and a lot of other people. We have done a lot of papers together. But what I want to show is that from this, when the war began, we were thinking, do we have a way to help with post-trauma that was about to become potentially more let's say more prevalent than before, and we started working on a technological tool. So we took people who were doing mostly theoretical work, which is like me and Amir, so we were discussing what it could mean, and started working on building something, right? Together with a group of volunteers from Microsoft Research and Development in Israel, and other experts on trauma, Professor Yael Lahav and Dr. Zohar Yosef. And so we started working on building the tool. And at some point, we realized that we don't really need AI at this point to have a very effective tool and to provide solutions. So putting that aside for now was really a way to reduce risks. And so I'm just showing that today. It got published on Jerusalem Post, so I just got it a few minutes ago. And I'm showing that because it's, okay, so first of all, it's exciting to see how industry and academia and governmental agencies kind of work together to figure out solutions. But also, how do you do that in a way that would be beneficial, but also would stand the regular rigorous tests of randomized clinical trials and so on? Can you do that? And what are the risks when this entails not just regular technology, but maybe AI? So, so enough about us. Today we're going to have our first English meeting of the seminar for this academic year. Just note that next week we're going to have another meeting. So it's the same time, but if you're in the US, then it's not going to be 9 a.m. It's going to be 11 a.m. because they're changing the clock there on March 10th. So today I'm really happy to present Professor Giovanni Rubeis. He's a prominent researcher in the realm of digital technologies in healthcare. In his PhD, Giovanni focuses on practical philosophy. So I talked about practicality, right? So applied ethics. His current work on machine learning applications, artificial intelligence, and big data analytics in healthcare looks at various fields in healthcare, including mental health, nursing, and other professions. And he looks at the transformative aspects of connecting technologies into the work of these fields. And his coming book looks at that. I understand it's going to be sometimes around April. So good luck with that on Springer Academic Publisher. And it's really great pleasure to have you here. And I would like to give you the floor, Professor Rubeis, and would love to hear your thoughts. Something like 40-45 minutes, and then we'll have time for Q&A.
Okay, so sorry. I apologize for this. And another thing that I have to apologize for, which Oren already apologized for, which is totally wrong because he didn't make any mistakes. I made the mistake last week. I kind of messed up the time zones, and yeah, this happens even still today. And an AI assistant would have been great. So I'm very sorry if you were there, if you attended the seminar last week. It was my mistake, but I hope that today I can make up for it. So, as Oren already said, what I'm going to do today is not talk about AI in medicine or something like that, but be a bit more specific and give you like the gist of what the essentials of my upcoming book. And you would usually expect in a talk like this that I tried by outlining all these technologies that are out there and what they do and all of their advantages. But I think that this is something that you can hear anywhere, and I think that you probably heard this many times. So I will do without that. Let's just say that AI is a bundle of technologies, machine learning technologies that are designed to deal with big data, with huge amounts of data. And in medicine, this is a tool that is an ideal tool, because in medicine we are used to deal with huge amounts of data already now, which is a big challenge for doctors usually. And these technologies open up new ways in medicine for practically every aspect of what medicine means. And this is really the idea of my book. Not so much focusing on the technologies themselves, but what they do and what transformation, what changes they cause in medicine. So this is the main focus of my book. And what I'm trying to do today is to give you a short introduction into that, to outline this transformation process on the one hand, and on the other hand, I want to outline two risk factors that I see here, despite all the huge advantages that these technologies will bring us. I see two huge fields or two huge aspects that will become major issues. But these are issues that we can deal with and should deal with. But first, we have to analyze it to to get a clear concept of what we are dealing with and what is to be done. What are the strategies that we need to use? So first of all, as I said before, AI will have a huge impact on medicine, and some people talk about a revolution. Some people talk about a disruption. What we can say is that there are three impact areas that we can identify, and this is for one, practices. AI as a tool will and does already transform the way we do things in medicine. So it provides us with new ways of collecting and analyzing data, especially. And this is what I call smart data practices in medicine. So doctors, of course, nurses, psychiatrists, and so on, already have their data practices. They have their ways of collecting data, of analyzing data, of operationalizing data, but AI will completely transform this these processes and these practices. And this means a new way of reading and treating the patient. So reading the patient means the whole patient encounter will change, because medical professionals will increasingly deal with data models before they even see a patient, or they will focus in some cases exclusively on the data model and not so much on the patient as a person. And this has enormous advantages, but it also comes with huge risks. The other impact area that I identify is environments. On the one hand, we see that these technologies transform the work environments of health professionals by workflow optimization, for example, and by transforming the data practices. On the other hand, another environment that will be transformed is the private realm, the private environment of patients and healthy persons that use AI-based health technologies. Most of these, or some of these technologies, are smart wearables or Internet of Things applications used in the daily lives, in the home environment of persons, and as such, they transform this hitherto private space of people. The space becomes kind of permeable because of the constant data flow that occurs there. And for better or for worse, this changes these private environments as well, and also the work environments of doctors. And the third impact area is relationships. Using these tools will mean rearranging established relationships and also transform established roles in medicine and healthcare. On the one hand, because the encounter, as I said, between health professionals and patient radically changes. This changes also their relationships. It affects things like trust, like privacy, like empathy. It may also empower and at the same time, in several cases, undermine autonomy of patients, and thus have a huge impact on the relationships we're dealing with here. And another aspect that is often overlooked in especially in ethics research is that AI in medicine means introducing a new agent, because many, if not most, AI tools are not just mere passive tools, but have a certain kind of autonomous or semi-autonomous functioning, which means that in a way they can make decisions and they can set actions on their own without any human guidance for doing so. And this means that they have not the status of a passive tool, but rather of an agent, of an active agent that plays an active role in these in all these settings. And this means the hitherto the relationships in medicine, patient-doctor relationship, for example, or the nursing relationships that were hitherto first and foremost seen as dyads, as bipolar relationships, now become more dynamic because this new agent is introduced here. And this will, we don't have a concept for this kind of relationship yet. And this will also transform the roles of doctors, of patients, of nurses, of therapists, either empower them, enhance their roles, create new tasks and new possibilities for them, or take over some of their duties and some of their tasks by outsourcing them to these agents. But the important thing is that we don't really have a compass now for how these roles might look like in the future, or how these relationships might look like. So this is the basic situation that we're facing when we talk about the transformation process that is going on in medicine and healthcare through AI. And this means AI is not just a smarter, a newer, a better, a more precise tool, a more precise scalpel or a stethoscope or something. It's a totally, it's like a force that transforms medicine and has a huge impact on these three areas: practices, environments, and relationships. And this transformation, I call it a transformation, not a revolution or a disruption, because this transformation as such is not inherently a good thing or a bad thing. It's first and foremost an opportunity. It's an opportunity to realize a concept that has been around for years, for decades now, and this is often referred to as the 4P medicine, where these P's stand for predication, personalization, prevention, and participation. That means that by using or by combining multivariate data from all areas of life, and especially using monitoring technologies, mHealth technologies like smart wearables, or Internet of Things applications like sensors and monitoring systems in home environments, we could get better data, more personalized data, also data that is not obtained under lab conditions, because a lot of data in medicine that we're dealing with comes from lab conditions, right? Or these data only provide a kind of a snapshot. If I go to my GP and he does a blood draw, all he gets is my health situation at this very moment where he did the blood draw, right? And he sends it to the lab sends it back, and he has all these numbers and all this data, but this is just a snapshot in time. Whereas especially mHealth and especially sophisticated data models that can be dynamic and updated can show us longitudinal data that are not only obtained in a GP's office or in a hospital, but in the daily lives of people. And this is much needed environmental and behavioral data that can refine the other data we have. Because as you might be aware of, most health issues that we're dealing with nowadays are primarily health issues related to environments and to individual behavior. So more data on these aspects, like cardiovascular diseases and so on, you know about that. And more data on these aspects would mean that we have a fuller picture of an individual. And this means better prediction. We can better predict health outcomes by building data models from this, better personalized data, because we are using individual health data. This can be used for preventive measures. We can, instead of doing something against a disease when it is there, we can prevent the onset of diseases by, for example, suggesting a more health-conscious lifestyle, and by using mHealth technologies, especially, we can include persons in their own in dealing with their own health. This is the participation aspect. So patients become active participants in this whole enterprise instead of being passive recipients of doctors' orders. This is what this participation aspect is about, and this also means empowerment of patients and a more patient-centered medicine with a focus on individual needs and resources. Hitherto, medicine is focused mainly when it comes to the evidence base for medical interventions on large cohort studies with thousands of participants. But these studies give the individual doctor only the average patient, so to speak. from a research paper, from an RCT or a meta review, and the doctor then has to figure out how can I use this data from thousands of people with this average patient in this individual case. And dealing more with data directly collected from patients can, of course, mean a more personalized treatment that has this focus on the individual needs and resources. And AI and big data are the crucial enablers here in this respect. And the vision, which is by now still a vision, but will become, I think, the great breakthrough in the next 3 to 5 years. It was this what is discussed as digital twins, and digital twins is really would really be the most promising manifestation of what AI and big data in combination can do in medicine. A digital twin is a virtual model, and it can be a virtual model of, let's say, an organ or a structure, for example, a cardiovascular system, or of a whole person. So you can model the whole bodily functions and the whole bodily makeup of a whole human being, depending on how good your data is. And the idea is that digital twins are more than just models, in that they are bidirectional and dynamic. Bidirectional or dynamic means that data can be permanently updated. You don't have this snapshot, as I said before, when you do a blood draw and you have this lab results, but you have this data model and you can constantly feed it with new data, for example, from smart wearables, from new lab results, from IoTs and so on, and keep it dynamic so that you can also simulate what happens over time and what will occur. So risk management, risk prediction becomes much more precise. And it's bidirectional because this data model is the basis for the intervention of a doctor. So he or she chooses a medical intervention based on this data model. This intervention also generates new data, which is fed back into the model, which then can be used for further intervention. So this is a kind of a feedback loop, which makes this much more interesting than conventional models in medical treatment. And you can feed all kind of data into it, lab results, data from the electronic health records, or as I said, from smart wearables. And you can basically get data on everything, on genetics, autonomy, physiology, pathophysiology, the environment, and the behavior. And it can be used for predicting and preventing risks and personalization. For example, predictive data analysis of disease progression, but also, as you see here in this graphic, for drug testing. Instead of figuring out from research papers what might be the best drug for this and that disease, and then give it to the patient, you have to figure out is this the right drug, is this the right dosage, and so on. It's a process that takes time, that is potentially risky. Instead of that, you can just model that. You can just use the digital twin. You can simulate giving this drug to the patient. You can simulate that on the model, and the model tells you this drug in this dosage, based on the data we have, is the right choice. And this is fast, it's easy, it's risk-free, it's better. It saves resources, and it's also better for the patient because you don't put him through the ordeal of potentially testing several medications until you have the right one. So personalized treatment based on individual health data will be the future, especially with a focus on prediction and prevention. We want to prevent diseases before they even before their onset, because it's better for the patient. And of course, especially in health systems based on a solidarity approach, you have this idea of you have finite resources, especially financial resources, and you have to be cost efficient and cost effective. And this is what you want to do. You want to use a very effective model that saves a lot of time, a lot of manpower, and a lot of resources. So everybody wins in this scenario, and this is really the way to go, and would be an immense breakthrough on all levels in medicine, from GPs to clinic doctors and so on. But that said, it comes with a bundle of risks, and one risk I will debate especially two here. One is what has been called digital positivism. Of course, dealing with data that way requires us to focus on numerical data, on quantifiable data, on data that is available in a certain data format. And this is something that will have an immense effect on what could be called the heuristic practices of doctors. Clinical heuristics can be seen as a link between epistemological and normative aspects because the way a doctor encounters a patient, reads a patient, influences their decision-making, which in turn, of course, influences or has an impact on the patient. Heuristic practices can be understood as interpretation and handling of data as a basis for clinical decision-making, and usually doctors are faced with a large amount of data, and they have to use shortcuts, mostly based on their experience and training, sometimes also shortcuts based on cognitive biases to make sense of this data, right? So, as I said, the example of the blood draw I used before, the blood draw gives the doctor a lot of information. Not all of this is relevant, so the doctor needs a strategy to cut through all the noise and figure out what is the information I need in this specific situation. And this is one of the main skills doctors must have to handle large amounts of data. This heuristic practices, and this also includes a distinction between relevant and irrelevant data. It is a selection where doctors have to figure out what is the data I need and what is just noise. And this is something that needs a lot of training and a lot of experience to figure out. When we are faced with big data and not like the data that is presented to a doctor in the lab result from a blood draw, but the really big data that a doctor can be faced with all these data from all these multivariate sources, of course, this means a huge challenge for the heuristic practices. So AI is, of course, the ideal tool to make sense of all this big data. When we talk about big data, we talk about two things that are of major importance. One is the superiority of big data. That means, in an epistemological sense, we think that big data is always superior to the way we hitherto used to go about data, the very limited data sets that we have used until now. So that means quantity is a factor here. Precision, of course, is a factor here, and objectivity, because of course we think big data analyzed by AI is more objective than just people going through the data by hand, so to speak. This is one aspect. The other aspect is inherent value, because we think that, which is the basic premise of big data, we think that by making correlations, by correlating data points with each other and processing them by using algorithms, we can kind of make sense of the data, and we can use this inherent value that is already in the data with these very sophisticated technologies. And this gives us a better practicability. That means benefits for healthcare, but also for research and even for administration. This means a more efficient data use. So efficiency is a topic here, saving resources and costs, especially human labor, because a lot of time, doctors spend a lot of time on collecting data and making sense of data. And if you can outsource these processes that are sometimes very tedious, very repetitive, very mechanistic, if you can outsource these processes, it would mean an immense saving of working hours, of human labor. And finally, optimization. That means we want this precision medicine. We want the data to be as precise as possible, not only for treating the patient, but also to optimize workflows, which is also, of course, a resource thing. The danger that comes up here, that arises here, the risks that really comes with this focus on this numerical data is what has been described as digital positivism. So digital positivism means that all these big data practices, all these AI-based practices have two premises. First of all, they rest on this idea of datafication, meaning that we can, in principle, quantify all aspects of life, all activities, and all manifestations of life, behavior, environment, and so on and so forth. So these are all, in principle, quantifiable. This is one aspect, and the other is what has been called dataism, which is kind of an ideological belief in datafication. It's the belief that datafication is not only possible, but always superior to any other sources of knowledge or information. And there's some ideas connected to this. Data speak for themselves. They have objective, they are objective images of real objects or processes. So they are mirror images that depicts reality. They have an inherent value and an inherent meaning. And this neglects that data collection and processing, of course, are in themselves social practices that depend on the whole social fabric in which they take place. They depend on decisions that have been made. They depend on goals that have been set for these processes. But if you focus on the inherent value of data, you kind of neglect all these aspects and ascribe an autonomy to this data and an inherent value and meaning that might not be there because you totally lack all context for how this data was generated, why it is the way it is, and so on. So ignoring the role of economic, institutional, and political agents that shape data collection and data analysis means that you only have one side of the coin, and you see only one aspect, and this is the aspect that is quantifiable and that is represented in all of these data sets, but it tells you nothing about the context and the bigger picture of which these data are part. So the main risks here is that statistical results that are, and in principle, all these technologies give us statistical results that are detached from a context of data collection, might mean or might imply that we don't have much information about why the data are the way they are. We have no analysis of meanings that might be necessary to accompany these data of the human experience or of ethical aspects. This digital positivism also ignores the ambivalences, conflicts, and contradictions that might be in the data, because sometimes they just show up as noise in this data and are thrown out simply because you can't make sense of them. So it's not relevant for our model. But that does not mean that these ambivalences and so on cease to exist simply by ignoring them. And the focus on efficiency and efficacy may mean that we think that a smooth workflow and smooth work processes are better than focusing on why there is an ambivalence, right? Because this is kind of abstract, I give you an example what it means to decontextualize data and just focus on these quantitative aspects. Several years ago, a very significant paper has been published in Science that triggered an immense debate that is still going on, a paper by Obermeier et al. On racial bias in healthcare algorithms. And what Obermeier et al. Did was they focused on an algorithm in the US healthcare system, that was used as a decision support algorithm. What this algorithm does is it sorts patients into risk categories to determine access to health services. So the algorithm has learned that if there is a person in which already huge health investments have been made, this means in the future, it's very likely that this person will also need medical services. So it will also need, this person will also need health investments in the future. Thus, it has a higher risk score, and it's sorted into the higher risk group. And the higher the risk group, the easier the access to health services. Makes totally sense, right? If you think about it. However, using health costs as a parameter here totally ignores the context in which data is collected. Because in the US, we know that less health costs are invested into Afro-American patients or Afro-Americans as a group, but the algorithm doesn't know that. The algorithm does not possess this contextual, cultural, social, political knowledge, and simply looks at the quantifiable data and naturally defines the risks of Afro-American patients as lower than they really are. And this means that it creates another access barrier for a group that has already huge access barriers to face, and then means less health services for this patient group, which is one of the patients group that could profit most from a system that really ascribes them a risk label according to their individual data. So if this would be personalization done right, Afro-Americans would be exactly one of the group that could profit the most from this. But if we focus too much on quantifiable data and quantification and all this datafication aspects without the context, we will fall in exactly this kind of trap. What does this mean for the heuristic practices of doctors? Medical practice always implies contextualizing objective data with individual characteristics. This is one of the first things doctors learn in their practice, and this is why medicine is an ars and a scientia. It's an art and a science. It's not simply applied human biology. It requires this skill of making sense of data in the face of an individual patient, right? So we have to understand what data is, what they can do, how data is constructed, how data is collected and analyzed. We have to understand the whole social practices behind all these processes in order to really assess the epistemological value of this data. It has, of course, a high epistemological value, but we have to contextualize it, and we have to also know about the epistemological limits of these data models. So critical data studies is a field that is highly relevant for medical practice, but also for ethics, because it shows us exactly that. What do we mean by data, and where are the limits for our data models? And in a data-intensive medicine setting, we need such an informed understanding of data based on this critical data studies in order to really achieve the personalization and the whole 4P medicine as a goal that we want to achieve. And this is only possible if we minimize this digital positivism. Of course, medicine is always based on a certain kind of positivism. We need that, and we also need a certain kind of digital positivism, because we somehow need to transform all these messy, complex phenomena into clear, quantifiable data. But we always need to be aware of the context and the social practices behind them. Another aspect that I want to talk about. So the first risk is this digital positivism. The other risk is that we are entering a phase where we primarily focus about surveillance. We focus on prediction and prevention. So we don't look at the patient anymore purely in the medical field or from a medical point of view, but we are increasingly looking ahead. We're looking into the future of the patient. We are focusing on lifestyle and so on. And some when they hear surveillance and surveillance in healthcare, the first thing that comes to mind, of course, is Foucault and his panopticon idea. And I mean, the intensive use of IoT technologies in the home of patients and smart wearables and so on, monitoring systems, sensor systems, and so on, might suggest that we're dealing with a kind of panopticon situation. And as you may know, Foucault introduced this idea of a panopticon as an ideal tool where this watchtower is located in the center of a rotund that contains cells. Also, Jeremy Bentham already spoke about this, where guards can watch prisoners in their cells at any given moment. The prisoners cannot see the guards, never know when they are watched, and the prisoners adapt their behavior without direct coercion or force, because mere surveillance alone, rather than brute force is used to discipline them. So this is enough. So the surveillance is not innocent. Surveillance has this potential of a disciplining force that can be a result. And this has hitherto been the framework for exploring normative aspects of surveillance. But I don't think that it really works in our scenario right now, because the panopticon suggests this rather rather rigid systems like clinics or prisons and so on. But now we have a totally different situation with the medical gaze, the clinical gaze entering into the private realm, penetrating the walls of the private realm, and being ubiquitous and always around you. So the panopticon idea doesn't work anymore. I prefer Zygmunt Bauman's idea, considering new surveillance technologies that he came up with already in the 90s, and then post 9/11, where he focused mainly on the terrorism threat and how minorities, how strangers, and so on were framed after 9/11. And he considers that there's a shift from a monitoring conducted in clearly defined space, such as prisons or hospitals, and by human actors, such as prison guards or doctors, to an ubiquitous and automated surveillance, where we never know, is somebody watching, or is this just an automated system, and does this really make a difference? So surveillance becomes ubiquitous and flexible, or what Bauman also calls liquid. So he speaks of liquid surveillance that is not bound to this rather fixed places, but is free floating and liquid. And the result is that persons are increasingly disassembled into data packages according to specific traits, for example, health data, and then reassembled into a data double. Think of digital twins, and this data double, this data model of a person, is then considered as objective and representative, as a benchmark also for decision making and sorting. And I think this idea of a liquid surveillance is much closer to what we are facing now. And so this brought me to reconsider what this kind of liquid surveillance in terms of health data collection means for health and medicine. And I think it influences medicine in three ways. First of all, we see a process of liquefying health and illness. Now, we have concepts of what health is and what illness is, but I think the lines between them become rather blurry through these new digital health technologies. On the one hand, we have this risk-focused medicine that is always about potential risks in the future, prediction and prevention, which led some commentators to refer to this as individuals on alert. So you're never really quite healthy, you're just not ill yet, right? So health becomes something that is not clearly not clearly defined. You can grasp it anymore. It always evades you because it becomes so fragile and so liquid. It's always in flux. It has no stable condition because of this permanent risk focus and the constant danger that you are faced with. And this also not also implies talking about risks, but preventing them, right? Interventions for risk prevention. So surveillance and care go together, and this creates what has been called a flexible body that requires constant surveillance. So even before we had all this surveillance technology at the ready, even in the 90s, this was something that some commentators foresaw, that this focus on risk will create this flexible body. Where you see it as an individual task to permanently care and take responsibility for your own body, and constantly monitor and measure everything. A quantified self movement is a good example for that. And the predictive focus on risk prediction and prevention kind of legitimizes all kinds of surveillance in medicine, because you can always say, well, it's for the so the patient is the one that benefits from it, right? So it's totally legit to do this, and don't worry about all the ethical issues here, because it's something that we do for the patient. The second aspect where liquefaction I think plays a role is what becomes liquefied is the borders of the medical domain, to a certain extent, because hitherto we had these clearly defined spaces. Here is the medical domain, GP's office, hospitals. Here is your private realm, and now, as I said before, the private realm, the walls of the private realm become permeable. Self-monitoring and self-management become a clear focus. There's an ubiquitous and permanent data transfer from your daily life, from your home environment, and you're supposed to do this self-monitoring and self-management, not only because of health reasons, but also because it is seen as an empowerment. So you can participate in, you can take your health in your own hands, and this is something that is very positive, and you should do that, which also means individual responsibility and control is something that we can ascribe to individual persons. So you are responsible for your own health. And what we often see here is that this empowerment is in fact more of a privatization in what Bowman has described as a consumerist individualism. So it's not really that you have responsibilities, but also rights. You primarily have responsibilities simply for financial reasons, because it's much cheaper for a healthcare system to outsource all these risks and ascribe all these risks and as responsibilities to the individual, then deal with health risks in a collective manner based on solidarity. So this means at the same time we have a process of desolidarization and expansion of the medical domain. So you should be responsible for your own health to a large extent, but at the same time, the medical domain expands instead of getting smaller, because it defines your tasks and it enters your private realm. And finally, the third area where liquefaction takes place is the roles in medicine. I already mentioned them earlier when I talked about relationships. So we are faced with new roles, mainly because of this focus on participatory tasks, or this participatory aspect of AI-based health technologies. So surveillance and self-surveillance, as well as data sharing, is seen as an empowerment, because, as I said, you can take your own health into your own hands, which empowers, or is supposed to empower, the individual, and at the same time should lead to a democratization of healthcare, especially the doctor-patient relationship, which is a power asymmetry, of course. And now this is supposed to be democratized by leveling this power asymmetry within the therapeutic relationship. But what is overlooked here is as I said before, the role of commercial agents that enter, of course, this therapeutic relationship. And the thing with digital technology is, and maybe you're familiar with this idea of surveillance capitalism, they don't just sell you a product, and they are not interested in the money you pay for their product, for their app, for example, or their service. They're more interested in your data, in your metadata, especially. So this is really the cash cow here, not the few bucks you spend on a health app. And this means that a new agent with a totally set of interests that is not necessarily the same as the patient's best interests enters these therapeutic relationships. Doctors, we can expect to act in their patient's interest, but with these commercial agents, we cannot be sure what their motives really are. And this has an immense impact of doctors, because they lose their gatekeeper role when they are when they have to deal with app stores selling people health apps with a shaky evidence base at best, and something that is uncontrollable from a medical point of view. So health and surveillance is a huge topic, and this kind of ubiquitous and permanent surveillance that is necessary in certain respects to fulfill all these promises of this 4P medicine comes with the risk of disciplining instead of empowerment, or enabling the quality of life, given the permanent surveillance and the opportunities this means for commercial agents, but also for governments to just use this as a tool for their health agendas, for example. And all these surveillance practices kind of suppress ethical evaluation, because you can always say, well, it's for the benefit of the patient. And the main risk, as I said, is engendering health agendas on the one hand, or economic goals instead of individual well-being. So we have these huge advantages on the one hand that AI-based technology gives us. And on the other hand, we have these two main risks, which is digital positivism and this liquefaction process that we see here, based on this connex between health and surveillance. So what can be done? What are strategies for dealing with that? One would be to focus more on critical data studies in medical education and training. I think it is very important that doctors need a better understanding of what data actually are, and especially what digital data actually are, what they can do, what AI is, what AI can do, where the epistemological advantages are and where the limits are. We need participatory technology design. If we want to design technologies that are supposed to work for every patient group, we need to include those, especially minority groups that are still underrepresented in clinical research and are underrepresented in technology design. One of the best example was a software, Google's mother company, Alphabet presented 3 years back. They presented this new computer vision technology for melanoma detection in dermatology, a software that could detect melanoma on pictures you could just take with your smartphone. This system outperformed human dermatologists in recognizing melanomas, which was pretty cool, until someone found out that the training data for this algorithm consisted only of 4% pictures of people with non-white skin color. So the system is totally worthless if you have a darker skin tone. And this is one good example for how important it is to have this participatory technology design that is aware of diversity in societies. Another immensely important aspect is that well-being and empowerment can be defined as potential of these technologies, but they don't come with the technologies with the technology itself. Simply by implementing and using these technologies, we won't see well-being and empowerment, but we have to define well-being and empowerment as crucial goals already of technology design. And this is where we have to focus on. It's not enough to design technologies, use them, and then deal with the fallout later. We have to prevent some of these ethical issues by really defining the goals, that we want to achieve with these technologies, and then think from there and think about what is this technology supposed to do beyond its mere functioning, and what are the goals connected to well-being and empowerment that we want to achieve here. And finally, with many of these technologies, we need a human-in-the-loop approach as a kind of control mechanism. This starts by fine-tuning algorithms, for example, or by choosing the adequate data sets. Think of the alphabet algorithm. Obviously, you need someone with a basic understanding of social diversity to pick data sets for training data that are adequate. But also in certain other steps of the data analyzing process, different human-in-the-loop approaches would be important as control mechanisms. So this is my take on the topic, and of course it's a bit difficult to condensate a 300+ pages book into a short presentation, but I hope I could give you the basic idea of what this book is about, and yeah, the rest you can judge for yourself in 6 weeks or so. Thank you very much.
Thank you so much. And you may stop sharing the screen so we can start sharing our own videos. You've mentioned so many issues, and before I hog the conversation with my thoughts, I'm happy to open up our floor for questions from the audience. You may either raise hand or just open up your microphone, please. Notice that I'm holding myself because I have so many questions. So I'll talk, and we'll see if people warm up to us. So you mentioned a lot of issues, a lot of concepts, and I'm wondering about some of them. If you have some more advanced thoughts, I'm sure you do, that you can share with us. So, for instance, you talked about a new agent in town, right? So the concept of agency is both a philosophical one and a psychological one. And I think the distinction you made was that when there is some kind of semi-autonomous functioning, that's where we need to maybe consider that this is not just a tool, because it's doing things on its own, right? Now, when you think about that, do you have any do you think about it as something different than, like, what do you mean by an agent? Why does it matter? What are your thoughts?
I mean, there's a huge debate going on the how we frame AI systems, and of course it's much easier to think about embodied AI systems, such as robots, for example, or when you have an avatar or something, because it's more anthropomorphic and you can relate to that more, or you are more susceptible to ascribe some kind of agency to such a system. But basically, it doesn't matter if it's an embodied system or not. What the debate is all about is what do we need to define agency? Do we need something like making decision and so on based on reasoning, or what are the qualities? What is needed for that? And I must say this is a philosophical debate that needs a book of its own, right? And there are many books out there on this idea, especially what this means for our interaction with these actors. Because why you ask why this matters, and from an ethical perspective, of course, the main reason why this matters is if we consider these systems as agents, what does this mean for our interaction with them? Can we ascribe them not only agency, but moral agency as well? Do we have to treat them like we would treat any other moral agent? Can we ascribe responsibility to them, for example, is a very important question, especially in the context of medicine, where the first thing a doctor will ask you when you introduce a new technology, well, what about liability issues? right? So this is very important. Only also from an ethics perspective. Can we ascribe agency, and can we ascribe moral agency? And the other way around, do we have to treat, for example, a decision support system as a colleague? Does this system have the same status as a colleague would have? And in my book, what I'm trying to do is I define some AI technologies as artificial agents, but to me, this does not imply that they are moral agents. They are only what they do is interesting from a moral point of view, or is relevant from a moral point of view, because it can have ethical or moral implications. A decision by an algorithm can have, as we have seen with this example from the US American healthcare system, can have a huge impact on people, and is therefore ethically relevant. But that does not mean that the decision or the action as such is made by a moral agent. But I think we can safely say that some of these, depending on their level of automatization, some of these systems are agent in a sense that they make decisions or even set actions without any human guidance or without any human direct programming to do so, which is, of course, the main idea of an AI, that you don't, or of at least a machine learning AI, that you don't have to program every step, right? Yeah. And in that sense, I think you can define some degree of agency, but we should not make the mistake to say, well, agency means moral agency. What they do.
So we have a definition issue here, right? Of
as
terms
always
that we use and how we apply them in this regard. I'm going to let Damilare ask or say what he wants to say, just to complete that thought. So you barely made a distinction now between how the healthcare professionals are interacting or using this agent, and how potential patients or the wide audience is using it, if you mentioned democratization. And in a sense, maybe rightfully so, because if we are human, then the question of what it is that we are dealing with is a similar one to the professionals and to the ones using that data. But that's a distinction I would consider also putting in the mix, right? So I'm not sure that the healthcare providing using it would look at it the same way as the patient. And so my added question to connect to that, because it's connected, you talked about the dyad that now is potentially changing. It's not just me and another one, but maybe me and whatever it is. Do you mean the interaction of us with the artificial like the AI, or do you mean when the AI is there together with the doctor and the patient? What do you mean when you talk about the new kind of relationship?
I mean, both are possibilities. Right now, there's a huge debate whether AI will replace human doctors. And the tendency right now is to say, well, that's not the right question. AI will replace those doctors that do not use AI, right? So the ideal way now, or what we think of the ideal way, is AI as empowering and enabling and enhancing human doctors. So I think that, but anyway, that there will be, or there are already instances where we directly interact with an AI, for example, chatbots or something like that, without any human accompanying this. This will be something that will happen in medicine as well, or is already happening. But I think the standard case will be that I as a patient will interact with a doctor who uses some AI system. But this as well transforms the relationship, because as a patient, I'm not quite sure who is responsible here. If something goes wrong, is it the doctor's fault or is it the AI's fault? And the other thing is, I can have an empathetic relationship with the doctor, but do I have to include the AI as well in this relationship? On the other hand, what about the competence of the doctor. Can I trust in a doctor's competence when he comes up with a diagnosis and the AI maybe says something different? Who am I to trust in such a scenario? And finally, the AI as a tool shapes the way the doctor encounters me as a patient, because he is already presented with some kind of data model, and might not be very willing to look at more data at hand, and may not be that interested in interacting with me that much and focusing on me and my personal aspects, the whole qualitative aspects, because he has already such a superb data model in front of him or her. And this might also influence this this relationship. So yeah, I think this is why the status of AI as agent or simply tool makes a huge difference.
Thank you. Damilare, please.
Thank you very much. Am I audible enough?
I can hear you.
Oh, great. So thank you for the wonderful presentation. It was really nice listening to you and getting those perspectives to the ethical issues that can be found in AI. I'm a medical lawyer from Nigeria. In Nigeria, I always focus on the patient. All along, I was waiting for where, because as we all know, that everything must be patient-centered. At the end of the day, whether we call them the data subject, the data, whatever, they are still the patient. And you made so many valid points about commercialization, the fact that we do not know the intent of those who are creating the AI. Just before this webinar, I read something about AI in general. AI itself does not have the mind of its own. It's more or less like a child that needs to be told what to do, like an algorithm. So at the end of the day, there needs to be a standard. For instance, policies in place that can keep up, which is where the problem lies, that can keep up with the advancement in AI development, which is, I believe most lawyers would agree with me that we are struggling with recently, because it's moving really fast and we are we're running after it. So my question is this: you also mentioned something about gatekeeper. The traditional gatekeeper in medicine are doctors, health workers. Now we have other actors. How do we ensure that the responsibility transcends or go round in terms of when something goes wrong, we don't blame the AI. It's that we blame the user of the AI or the creator. How do we ensure? And then the second question is about cross-border nature of AI and technology. We come up with an international policy that can, for instance, if someone is using AI in Nigeria and the creator, let's assume the person that will be responsible for whatever goes wrong is in the United States. How do we ensure that such person is held responsible for the problem or the wrong use or treatment caused by the use of the AI?
Yeah.
So
Yeah.
Thank you.
Yeah, thank you. This is the highly relevant question, and I have a chapter in my book on this question of responsibility, liability, which is very complicated because the ideas also differ between different legislations, right? With different legal traditions and so on. So this makes it all the more complicated if we are dealing with systems that should be available or usable on a global scale. I mean, there are various concepts, and as you mentioned before, who's responsible? Is it the software creator? Is it the doctor that uses the AI? Is it maybe someone on the meso level, meaning the hospital or the medical institution that authorized this kind of technology to be used? Who is responsible? And there is this idea in ethics of what has been called disseminated responsibility, where you say that in such a so-called problem of many hands, you can't just pinpoint responsibility to one actor, because all these processes are so complex. You have to figure out who is involved first, and each and every problem and each and every case has to be considered individually. Now, from a legal perspective, this is, of course, something that is almost impossible to do, because, as you said, you need clear regulations, you need standards, and how can you come up with standards if you say, well, it's not clear who's responsible, and might change from case to case, right? So this is really a problem that we face right now, and this is also one of the reasons why many doctors are absolutely reluctant to use, for example, clinical decision support systems, because as a doctor, it's always important to know the legal aspects, to know the legal frameworks, so that you can be sure and be confident in making a decision. And if this is unclear, if you can be made responsible or held responsible for a decision you made based on the data available and based on the technology available, but it isn't your thought that this decision is wrong, is because the data model somehow is wrong, then of course this is not a good evidence base, or not a good base for decision making. So I think that this is also a case where we have to reconsider what are the ethical aspects of ascribing responsibilities. This is also something that has to do with who is a moral agent. And on the other hand, do we have any guidance from in the legal system that we can deal with? For example, if we liability aspects in other concerning other technologies. Could this be a model for AI technologies? And I mean, in my view, this is the $1 million question, because no one has figured out yet how to come up with a satisfying theory. That there are many theories out there, but I don't think that or I'm not aware of any legal system that has found the ideal solution for that now. I mean, we regulate a lot of things. There are a lot of policies in the European Union as well on almost every aspect, but responsibility yet is not really an issue where I see a good solution.
Yeah. So thank you. We have some $1 million lawyers on the group here. Let me offer my 2 cents here. So I think like the law can adapt and can maybe create new constructs, but I think there are quite a lot of important constructs today in the law. So for instance, you mentioned desolidarization. So in a way, one of the risks that you may attribute to the democratization of medical knowledge is the possibility of saying, well, now that you have control and we have empowered you as an autonomous participant in your treatment, whether it is mental health or other fields, now we expect you to do more for yourself. And so in the legal terms, this could be considered contributory negligence, for instance. So maybe we were not okay, but you were not okay as well. You should have done something. You could have diminished your damage by whatever. You should have known, right? So that's one way people may go. I don't think for now that could work so well. So at least if it goes through the medical system, not when I go and use, I don't know, like Bard or Llama or OpenAI myself and decide to treat myself with, some prompts that I'm doing, then I can do a lot of stuff. I can buy some books about, I don't know, medicine with the blood of dead sheep and do whatever I choose. It may be a problem, but that's my own decision. But if I go to a healthcare system and they're deciding to utilize, let's say, the tool that me and my colleagues have built there's a reason why they want us to do a clinical trial before they use it. And in the end, they will either cover it or they will have insurance, and there is like liability for products, and that's probably where it's going to go for now. That's my initial understanding of the matter. I don't think we're going to be quick to say that this is a person, and therefore, by the way, person and agent is not the same in the law, but so I mean, a company could be a person, which you know, it's not a person. So there are a lot of strange legal constructs. They're not the same as the philosophical constructs, and we should not use those two. And therefore, I think from a legal perspective, it's a bit it is a challenge, but I would actually focus first on the big questions, the human related questions, because I mean, we're talking about, if I use ChatGPT on the go and I enjoy how it's playing with me, and I'm telling him, now you pretend to be a patient who is unwilling to share information, I'll try to get it out of you, and he's being evasive. And I was like, wow, this is really good. You're so, and then he becomes stupid. I was like, oh, you're not, like, how do I have all those feelings towards this tool? I don't know. What does it mean? I don't know. We might need to have some patient education. We might have, we might think as a society, how do we relate to the interaction, and how do we teach, if it's a patient who's going to use it, for instance, how do we provide with psychoeducation or with whatever is needed for people to use it wisely and understand its limits, and so on. And as you talked about how doctors may rely on it too heavily, which I think relate to the concept of epistemic authority, right? So if you're the expert, then I'm going to take your words and assume that they're correct. I may say, well, I know nothing about it. I don't know if I'm going to have the ability to counter argument whatever you said. And there are other biases, but those biases exist without these systems as well. So in a way, I think that's why I would distinct the professionals from the layperson, because professionals should know more about biases and know that their colleagues might be right as well as the AI could be right. But I really think you raised a lot of questions, a lot of points here.
If I may weigh in, just as a short response to that, I mean, if we talk about responsibility and the responsibility gap that we have with doctors using AI, we're talking about two conditions that we need to ascribe responsibility to someone, and this is knowledge and control, right? I have to control, be able to control my actions, and I have to have a certain knowledge about the consequences. And if I don't have them, it's hard to hold somebody responsible. And if doctors use tools that they are really do not understand, like black box algorithms, for example, it becomes really questionable if they have a control in the full sense. And so it's really hard to ascribe responsibility to them.
Well, so one more question we have on the Q&A chat. What will happen with diagnosticians? I don't know how to say this word, doing differential diagnosis. So is the personal touch over? Is it going to be like digital medicine? So that's the question generally.
Okay. Well, I mean, this is a good question that shows what I meant before, the ways we frame these technologies. And I think that if we think of AI as a substitute or replacement of humans, I think we are missing that in medicine we don't have the same situation as, let's say, in product development or something like that, where we have processes that we have to optimize, and the better the process, the better the outcome, because we have to think about the distinct nature of medicine. And one of the most important, one of the crucial aspect in medicine is the therapeutic relationship. The therapeutic relationship is the enabler of so many other things. Autonomy without a functioning therapeutic relationship is impossible. Empathy is impossible. Compliance is impossible without it. And I think that we, as humans, need this relationship because we are not dealing with buying a car here or just ordering a product from a website where it's totally fine, or it makes no difference if a human being or an algorithm interacts with us. Medicine is about really heavy stuff. It's about health. It's about illness. It's basically about life and death. And these things are so intricate, and there are a lot of vulnerabilities involved here, that a certain human touch, as you call it, a certain relationship aspect will always be necessary. So I think we can substitute human labor in many aspects, or in many contexts in medicine, where human labor is simply wasted because a lot of the repetitive administrative stuff, a lot of data collection and analyzing data, humans are just simply wasted on this. Machines can do it better anyway, and they don't care. They don't get tired. They can work long hours on that. It's no problem at all. But for everything else, we shouldn't even think about substituting that, because we should find a way where humans and machines can really, in a way, work together in the sense of both have their advantages and their downsides. What AI does is it's very good at making correlations and recognizing patterns, but that's about it. Right. Sorting stuff and correlating it, right? Yeah. Much better than humans can. But causality, for example, is something that humans are very good at, and this contextualization, this background knowledge, this is something that humans can do. So why not combine the advantages and benefits instead of talking about replacing humans?
Thank you.
But if you define work optimization and resources and cost savings as the main goal, of course, the result will be automatization and replacing humans. Right. If you define patient benefits, this combination will be the best way.
Okay, so we are reaching the end, but I would like, first of all, to say that you didn't say coexist, you said work together, which I value. And we have one more raised hand by an analyst, I think. So, Dr. Liliana, are you willing to unmute? Would love to hear your thoughts.
Sure. Thank you very much. The answer to my question is probably in the book, which I haven't read yet. But I was wondering, what conception could there be of liability without responsibility, which go obviously together? And what is the meaning of liability when nobody's going to suffer? That means you said the program doesn't care.
Yeah.
So if I'm found guilty of malpractice, I will suffer. I will pay a price. There's a quantitative element of enjoyment, which is to be gained or lost. And the question is, where does all this come into the equation?
Yeah, this is actually one of my main arguments I use against the idea of AI as a moral agent. It's not my argument, I must say. It's an argument from that has already been established in the debate, that you can consider AI as a moral agent because you can punish AI for any kind of misdemeanor or something like that. So it suffers, as you said, it suffers no consequences. So the whole concept makes no sense. And this is one of the main arguments that I use why this absolutely makes no sense. So of course, an AI can never be the agent that you ascribe either responsibility or liability to. And it's also very important to see that there is no AI without humans behind it. AI is, as all technologies, always attached to and tethered to humans, because at some point, some human made the decision that this design feature should be in there.
Yeah,
So,
still, we saw the Sam Altman stand-up show now. The humans that are behind it are trillionaires. They couldn't care less. Sorry. Thank you very much.
These are very valid issues, and we will continue our discussion on similar issues, not the same ones though, next week, as we are having another meeting of the same seminar, this time with Professor Effie Villena, who's going to talk about ethical medical AI innovation from theory to practice. I want to take this time just to say thank you, Professor Giovanni Rubeis, for your very worrying, interesting, exciting, I'm not sure what I think a lot of things. And I think it's important that we are having this conversation and that we have experts from different fields weighing in. And
may I just say something? I know that I couldn't answer all the questions given the time, but please, if I couldn't answer your question, if you have another question, don't hesitate to write me an email. I'll be more than willing to discuss this with you.
Thank you.
And thanks for having me.
Thank you, everyone. Thank you for joining us, and thank you, Amir, and the people in the Samueli Foundation for helping us getting the things working like that. And hoping to see you next week. We're going to send you an email with the link to next week, hopefully to see you again. Goodbye for now.